Folks, before we came on today, our guest and I were just having too much fun, and I thought we better start this interview. We might do the whole interview before we started even recording. Our guest today is Dr. Evie Cunningham, who is the Chief Medical Officer of an organization called Cadence, which we're going to hear much about. Prior to this role, Evie served as the Group Vice President, Chief of Virtual Care and Digital Health at Providence. And she also, during that tenure, co-founded a company called MedPearl, an AI-assisted clinical decision support platform. She served even prior to that various chief medical officer roles, which we don't have time to go into. Evie is a board-certified obstetrician gynecologist, and she also holds an MBA. She is an amazing physician leader, and I've had the privilege of knowing her for the past few years. Super excited, Evie, to have you on. I'm glad we hit the record button, or otherwise we would have just had the whole conversation having fun by ourselves here.
It's great to see you again, Zeb. And I'm so excited to be here and talk about all things digital, beyond the walls, transformation. I'm sure this conversation will go in many different directions.
So, Evie, you were on 3 years ago, and what's really strange is you weren't part of Cadence then, but in your role as a digital officer, you were working with Cadence. And I remember even during that interview, you were excited about the work that was going on with remote patient monitoring. And so I'd like you to first give a elevator sort of description of Cadence so everyone is aware what you're doing now with Cadence and what Cadence is doing. But also, how do you feel now, 3 years later, about this body of work and it's sort of where it fits into the healthcare ecosystem, the need? What's the big idea here?
Yeah, so I'll just start with framing what Cadence does. So Cadence is a remote care delivery system. We provide tech-enabled services in partnership to health systems to provide and extend care beyond the four walls of the hospital and the clinics. So we deeply integrate clinically and from a technology perspective, from a clinical perspective, and from an operational perspective. We are almost like an extension of the medical group for the health system. And we deliver care in the home. So health system, PCPs, cardiologists, whatever, they'll order Cadence for their patients. And then we will take the ball, and we will enroll these patients in programs for congestive heart failure, diabetes, hypertension, where we do remote patient monitoring in the home. And it's not just technology and devices that we're giving to patients and then calling it a day. Like, we actually have a medical group that then takes all of the data and manages the alerts, manages the patients. And we also have mutually agreed upon protocols with the health system that allows us to titrate medications. So one of our big core value propositions and goals is to get patients into guideline-directed medical therapy so that they stay in good control and we keep them out of the hospital. We also provide a lot of behavioral coaching and support in that way. And the big picture, the thing that we're really trying to accomplish is we're trying to get patients in better control of their chronic conditions. We know that we are not doing a good job in the traditional care delivery model to manage chronic conditions. More than 50% of hypertensives patients and diabetic patients are not on guideline-directed therapy or not in good control. Less than 10% of patients are on GDMT for heart failure. So the only way you're going to be able to get those patients in control is with small little bits of incremental interventions in between their visits, their regular clinical visits with their patients. And so that's what Cadence is helping to solve. And we do it not in a fragmented way that's separate from the health systems, but in deep integration with the health systems, which is not easy to do, by the way. That is like one of the hardest things to do, but we think that's the way for it to be successful.
Yeah.
Now, big picture wise, like, why am
Mhm.
I super passionate about this? And
Yeah.
like, why do I think this is the way we need to deliver care into the future? Like, a traditional office visit, and this drives me crazy because I still see patients today as well. A traditional office visit is not an efficient way to manage chronic conditions.
Mm-hmm.
Like, we have to find different ways to meet patients. Um, and like, health doesn't just happen inside the four walls of a hospital or a clinic. 85% of health happens outside of it, or 90% of health happens outside of it. And so, how do we continue to extend our reach as clinicians and ensure the patients, like when they leave the office with the laundry list of things that they're supposed to do, that they actually have the support they need, the reinforcement they need, the education they need, the touch points and encouragement they need to follow through with what the doctor ordered, right?
Yeah. I think you just said so much in a short period of time. You know, I want to pick on a couple of things. One, well, let's start with one, which is you said the office visit is not adequate, and I think that really to me is probably the most important thing that I heard you say. In the past, you would come into the office, you would get diagnosed, you would get treated, you would get referred. Typically, that works for acute situations, but most of care today is not acute. Most of it, in terms of volume, in terms of numbers, is chronic, right? And so
Right.
this notion, right, of having these sort of once in a while, very, very abbreviated visits, trying to gather all this data on the individual, all this stuff, all these numbers in a few minutes time, try to figure out what to do, and then sort of give the patient, the person, the instructions for the next few weeks or for the next few months is, if you just stop and think about it, you would not create the system to work this way. You would
Mm-mm.
actually do it more like Cadence, which is, okay, you have diabetes, hypertension, heart failure, some chronic disease. We have to monitor you over time. And as we are monitoring you remotely, we're going to make adjustments in your medications, adjustments
Yep.
in your treatment. That to me, it almost feels like, and I'm sure I'm going to hear about this, but it almost feels like we should invert it. That the remote monitoring approach should be the main approach to taking care of chronic disease, and coming in should be the secondary. When we
Yeah.
can't handle you at home, then maybe you come in, right? It just, what do you think about? I mean, I've never really thought about it, but it seems like we've got it upside down. We've got it backwards when it comes to chronic disease.
Yeah, I mean, I think that like there's so many patients that we see in the clinic that we don't need to see in the clinic. And then there's so many patients who would benefit from having an ability. Okay, maybe they have a long-standing relationship with their doctor. I mean, I'm an OB-GYN. There's reasons patients need to come into the clinic and be
Right.
seen, or they need procedures or whatever. But we should be looking at every single type of visit that we do
Mm.
in the clinic and saying, does this need to come in? Like, do I need to prescribe birth control to a 22-year-old who's healthy and has no risk and no other medical conditions in an office visit?
Wait,
Right?
time out, pop quiz. I mean, I'm only doing this because I like you so much, and we're such good friends. Pop quiz. So why is it that we bring people in? Give me the one reason why.
Ding, 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 dollar sign, billing.
That's how we bill. That's the reason, right?
Reimbursement.
Right?
Reimbursement. But like when these remote patient monitoring codes got released, right? I think it was in 2019, and that was around the time of the formation of Cadence. Part of what they thought about was like, well, how do we invert the model if there's no reimbursement? Well, now there's reimbursement. So how do we actually like invert the model, but do it in a meaningful way?
Mm.
So what I described to you, our model where we're not just technology, we're technology and we're the medical group extension, and we can do actually like titrate medications, order labs, like so that we can actually get the patients into guideline directed care. That's actually not the med titration aspect of what we do, and the labs and that
Mm.
care delivery piece is not actually part of the CPT codes, like explicitly for RPM. But if you look at our data and our outcomes and like compared to like just doing the data only, like data capture only component, like we actually have like transformational data that shows that that's the model that really
Huh.
works to improve the clinical outcomes really significantly and
Wow.
reduce total
Hmm.
cost of care and reduce
Yeah.
total cost of care. Yeah. And we can get paid for it. So,
So are you, with your work, are you seeing, is it more sort of the more serious chronic, patients with more serious chronic diseases, sort of like the heart failure, maybe sort of more advanced heart failure, or more complex chronic where it's not just one, but it's multiple? What is the segment of the population that Cadence is
yeah.
seeing?
So we focus mainly on Medicare age patients right now. That's where we started because we
Mm,
know that Medicare really needs like solid solutions for
mm,
better managing the patient population, especially as the gray wave like continues, right, to explode. And so, or increase in size. So I like the average age of our patients is 72. So we
yeah.
have a lot of older folks, a lot of
Mm,
people
mhm,
who live in rural and underserved areas. Over 60%
yeah.
live in rural and underserved areas. We're in over 30 states. So we started with like focusing on that patient population and with the big three, which is congestive heart failure, diabetes, and hypertension. We also
Mm,
have two other programs, chronic care management and advanced primary care management, which involves a much broader array of chronic conditions as
mhm,
well. But we have like the big three that we do remote monitoring for. And then for the chronic care management or advanced care management, it's more care coordination and support, like wrap
mm,
around for those
mm,
patients. And we work with the health systems to determine like the clinical eligibility that
mhm,
is most appropriate for who should
mm,
be identified as a potential patient that could benefit from the program. That is then surfaced to the provider at the health system. We have this really cool like integration with their
huh,
EMR where they can
huh,
see inside the EMR, inside their workflow, hey, here's your panel of patients that are eligible or Cadence panel, like patients who are Cadence
right,
eligible. And then
right.
the clinician at the health system is still always completely in the driver's seat. They can say like, oh, I don't want to have this lady because I know she probably wouldn't want to do it or whatever. And
Mm,
they can either bulk order or they can order individually for their patients. And then that gets sent to us. And then we still have to outreach to the patient and get the patient to want to. So it's like, it's not like there's many like little checkpoints
yeah,
along the
yeah,
way so that when
yeah.
patients actually do engage, like they're
Hmm.
fully consented, they know their doctor is like interested in them being involved in
Hmm.
this. And I would say we've seen everything from, I mean, if you look, um, even the low acuity patients, so even like the hypertensive
Hmm.
patients that are in pretty decent control, or the
Hmm.
diabetic patients that are in okay control. If you look at our data, you
Hmm.
still see that over time there's little like times where they spike or they have alerts or they
Yes.
have symptoms. And even though we don't have to necessarily always titrate their medication, sometimes it's they forgot to refill their med and they fell off
Hmm.
the wagon, or
Mm,
they had like the holidays where they overate, and so we're constantly, even though they're in
mm,
control, we still help kind of with coaching and behavior modification to get them back on the wagon sometimes of their chronic disease, because chronic disease is a journey, right? It's a
yeah.
lifetime journey. It's not like oh,
Yeah.
3 months of treatment get me in control and I'm good to go for the
Yeah.
rest of my life. Like people have their ups and downs. And so we, sometimes patients stay on a little bit, especially with congestive heart failure, they stay on a little bit longer
Mm.
because they need that constant support layer
So
for them to stay in control.
that's a really important point. They stay on. So what I'm now inferring is that this service. So actually, what I love about the service is that you're going to the electronic medical record system of a healthcare system, and you're finding patients that could potentially be helped by having this remote patient monitoring, then you're providing the physicians a list and saying, hey, listen, we're offering you this service. Your healthcare system is offering this service to assist you in taking care of a certain number of your patients, this remote patient monitoring for patients with high blood pressure, diabetes, and heart failure. I can't imagine why any physician would say, again, there might be exceptions. Why, it just seems this benefits the physicians greatly in terms of helping them take better care of their patients. Their quality scores probably go up, their
Yep.
outcomes improve, which makes them look better. It serves their professional purpose. Patients get better, and they're not paying for it. So the system essentially is your customer. The system is saying, now, why would a healthcare system, a hospital system, hire you as opposed to maybe doing it themselves, right? And I shared this with you before. I had a conversation recently with an executive who literally said to me, I'd like to do everything myself. I'd like to have everything in house as opposed to using vendors. So, what do you say to that?
Yeah, so I've been on both sides of this because I've built programs and things like that in health systems. I have a couple thoughts about it. We definitely see a lot of health systems that try to build this themselves. They struggle to scale and they struggle to make it financially sustainable. But they learn a lot in the process. A lot of times we have health systems who have tried and they
Mm,
have a small program and they're like, we know we need to scale this. We've proved out
mm,
that we see value and now we're going to find a partner to do it. And so people ask
um,
like, who's your biggest competitor? I'm like health systems that are trying to build it themselves that
right,
typically don't have an ability to do it in a scalable way.
right.
It doesn't mean that health systems shouldn't try some of their own things just to like experiment and learn. But there's a couple of things that are important to think about. Health systems have a lot that they have to worry about right now. They have a
Mm,
lot going on. They have a lot of pressures in a lot of different directions. They need to focus. They have a core competency in hospital operations, making the OR run, making the ED run, making nursing, the floors run well. They have ambulatory care or ambulatory surgery centers sometimes. Now, we all know that a lot of health systems struggle to manage their ambulatory surgery centers very well, and that's why they use
mm,
a lot of partners for those.
mhm,
But a lot of them have clinics. They have clinics and they have ambulatory clinics, and they have a core competency in ambulatory care and standing up the clinics. What they don't have a core competency in is
mm,
developing remote care delivery systems that can scale and work very efficiently. And when you look on the other side, like now that I'm over on the other side, because we had a virtual care team, we had some RPM programs that we did in-house. They never scaled, by the way, but
Interesting.
like when now that I'm on the other side,
Right.
like the way that we organize our workforce, the way that our technology platform is structured and organized,
Mhm,
like on like which is proprietary. We don't sell our technology, but the way that all of our tech, our workforce, our workflows, how everything is organized, it's purpose built for remote care delivery. And I can tell you right now that what they have on the other side in the health systems is not purpose built for that. So what you end up having, end up having a couple of issues. You end up, well, we're going to have a little team and we're going to try to recruit some patients, but they're going to have like all these manual workflows because
mm,
their technology is not like
mhm,
organized the way that
mhm,
our technology is organized. They don't split up the work the way that we
mhm,
split up the work. They don't think about like the mindset of how you set up this work and split up the work and organize like the units and the productivity and everything. It's completely foreign to what we
yeah.
do in our standard operating models within health systems. So what I try to tell people is like, go do some experimentation to understand that you really um believe in this model
Mhm,
of care. And yes, there are going to be some edge cases or use cases that it makes sense for you to do some things in house, like post chemo for a special case for 25 patients that comes out of an oncology. Like there might be some small things that like make more
Hmm.
sense that you do something localized because it's super
Hmm.
specialized. But when you want to get population health impact at scale, like where you're hitting, we have a one partner, we got to 10,000 patients in 6 months, right?
Wow.
10,000 patients in 6 months, just boom, right? I mean, if you want to get to that level of scale where like we want to democratize this model of care for all of our primary care patients, for all of
Hmm.
our cardiology patients, you're not going to be able to do it in-house and
Yeah.
not spend millions and
Yeah.
millions and millions of dollars doing it. If you want to do it in a very economical way
Hmm.
where you're not having to make a massive investment in order to get this stood up with a partner with proven results, like partner with I hate calling us a vendor, but partner with a tech-enabled
Yeah.
services entity that can be
Yeah.
a good partner to you. Yeah.
Right. No, I think the argument that it is these there are certain things that are not core competencies for healthcare systems. And, it's always that age-old question of do you build it or buy it or partner, JV. And I think, if you do the numbers, run the numbers, it in many cases it makes sense. uh, and even time wise, to build up the competency takes time, right? It could take years to build up certain competencies. And so I think that's a great argument. What are your, so in terms of outcomes, do you have any sort of numbers in terms of, using Cadence to help with high blood pressure, diabetes, heart failure versus not using Cadence?
Yeah, I mean, we've been published now in multiple peer-reviewed journals. So we
Mm,
just recently had a publication in the Mayo Clinic Proceedings
yeah.
journal, which was in November, where we demonstrate an average total cost of care savings of $1,300 per beneficiary per year. And this was largely driven by a reduction in admissions. So there was a 27% reduction in admissions, and this is for over like almost 6,000 patients. So it's a pretty big cohort. And when I think about it at the individual patient level where I'm like, okay, how many strokes did we prevent? How
Yeah.
many MIs did we prevent? How many did we catch that we caught? I can't tell you how fascinating it is to
Mm,
see how many of these like arrhythmias or patients having an MI, patients having a TIA, like where we
mm,
catch it just because the patient doesn't feel well, we're 24/7 available and they call in and like we catch something probably before it becomes something even more serious. Reproducible results is the other
mhm.
thing that I say. It's like, it's not just one paper. It's like, let's do another paper and do another
Right.
study and like prove that the model is working. And let's do another paper and do another study and show that it's working. And I think that that's like
Mhm.
really important.
Yes.
Not a lot of like vendors or tech-enabled services companies out there spend as much time on
Yeah.
getting their research published. And
Mhm.
like that's something that like we feel pretty passionate about. And I really appreciate that about the company because I think it's important to get the buy-in from the clinicians because we're not doing this outside of the care delivery health system. We're doing it in partnership. So
Mhm.
if the clinicians
Mm.
aren't bought in, we're not going to grow and we're not going to scale and we're not going to be successful. So we have to make sure that we earn their trust and we earn their buy-in.
Yeah. No, that's fantastic. But the thing you do is you're kind of coaching and educating and nudging, and there's a relational component here. I'm curious as to how you conceptualize that part of what you do and its impact. Kind of, it's one thing to say, okay, you need to go up 10 milligrams on this medication, and what's the impact of that versus the impact of actually all the other stuff you do, which is not just the transactional part or informational part, but the actual behavioral part. How big a part is that?
It's a big part. It's a big part. I would say a lot of what we do, the med titrations are important because we're trying to get patients to a certain target or goal. And they are a vehicle and a mechanism from a pharmacological perspective to help us get there and to
Mhm.
help us get there safely, right? Making sure that we're addressing if there's a fall risk, making sure that we're addressing if there's an abnormal lab that
Mhm.
precludes a certain type of drug, those types of things. But then the other piece of it, to your point, is the impact of being a companion and a partner to the patient in this journey that they're on. I can't tell you, there's
Mhm.
so many countless stories of patients who like are so grateful because I didn't
Mhm.
understand what it meant to have congestive heart failure. It's like,
Mhm.
maybe they heard when they were in the hospital,
Right.
hospitalized, or they heard from their cardiologist, but it's like the first time somebody hears that they have cancer, like it doesn't always
Mhm.
sink in what that
Mhm.
means. And we know that CHF patients have a high risk of mortality and lifespan challenges that are similar in some ways to a cancer diagnosis. It's not viewed that way, but like we do a lot of education about like what their disease means, what their medications mean, why it's important to take the
Mhm.
medications, like how do we work on. The other thing is it's
Mhm.
overwhelming for patients. They come into the doctor's office, you need to lose 15 pounds, you got to change your diet. I'm going to add this medication. I'm going to send you for all
Yeah.
these labs. And they're like, oh,
Yeah.
and
Yeah.
half the time they don't follow through. Well, we're
Right.
like nudging to your point of like, did you get all this done? Can I help you get your
Right.
referral completed? Do you like, we've worked through countless social determinants of health issues, whether it's supporting the patient to get a coupon for a
Mhm.
drug that they can't afford,
Mhm.
transportation issues, housing
Mhm.
issues. Like we've helped with so many
Wow.
things that, that's a huge part of your journey. And the other thing is like a lot of these patients live alone. They live alone. They're aging alone or they're aging with their partner
Interesting.
alone in their home. Over 20% of our patients have
Mm.
caregivers who are getting the daily texts and messages from us, and they're seeing that their mom or their dad or their grandparent or their sibling who's elderly at
Mm.
home is checking, and they get peace of mind seeing that like we're kind of this extra layer that's helping to sort of watch
So,
over
so Evie,
their
again,
family member.
yeah, I think as the last few months, I've been really formulating a kind of a reframing or reconceptualization of what we actually think what has impact in healthcare. So yes, I hear you say we check the blood pressure or the sugars, or we monitor weight or, and heart failure, et cetera. So we do those things and we adjust medication. Part A of what you do, part one. But then, oh, and by the way, we also we actually teach, we
Yeah.
talk, we discuss. So people have a better awareness, understanding of what's going on. Part, second part. Third part, oh yeah. So we actually help them in terms of actually getting these behaviors done through, whether it's scheduling, helping medications, transportation. So we help them with the actual behaviors. And then part four, well, we're also kind of like a partner. You actually use the word where we partner with them. Where it's almost like you've set up, and it's not just the individual. You partner with their immediate, whether it's family, caregivers, et cetera. So you're setting up sort of a community of health, if you will, around the individual. And so it's whereas one, again, with the traditional mindset, it's like, oh, okay, you're sticking you're checking the blood pressure at home. I get it. You give, basically you adjust meds. I get it. But I think that the impact, if you break it down that way, I'm almost wondering if the greatest impact is actually more on that partnering
Community.
side.
Yeah.
Yeah, the community side. And I'm kind of,
Yeah.
I think, again, I think the one of the reasons we have been so ineffective in controlling chronic disease, and we are ineffective when you look at the numbers, particularly the three you mentioned, high blood pressure, diabetes, and heart failure, is this lack of understanding. I think we've forgotten that we're people and we're taking care of people. And people aren't machines and they're not robots and they're not computers, and you can't just punch something in and expect it to come out the other end. we live as social beings, and you're right. We have agency. We have to understand what's going on. We have to understand the context. You don't get things accomplished alone. I mean, it's just you accomplish things. I mean, think about, you're an OB-GYN. You would never go into the OR by yourself, right? I mean, right? I mean, you have a whole team around
Yeah.
you. And I think even professionals know that, much less like an individual. So I really wonder if the value proposition, and then you say you leave after a while, you don't, you stay with the patient for a while, and then they're on their own. And I think what you've helped them do is essentially create the habit of health.
Right.
And so that, right. And so I just, again, I think we are so focused on the transactional, in part because we're science-based and oriented on interventions, and we get paid that way. And the real stuff, I think that actually, closes that final gap, that actually makes things happen. We sort of lose sight of that. I'm said a lot, but I'm just really, really curious your thoughts, and you may not agree with me.
No, I actually think you're right. I think that community of health concept, or having some sort of like, how do we wrap around the patient after they leave the office so that they can make sense of all the things
Mm,
that they're being advised to do, and that they feel bought into it. And it's also like not like, so I talked about how 40% of the time when we call the patient and we're like, hey, like your trend kind of indicates that we should probably maybe make some adjustments to your meds. Like, are you taking your meds? And like 40% of the time we find out, well, oh, they're confused about their meds. They couldn't get their meds refilled.
mm,
They forgot to take their meds. They don't think they need meds anymore because they feel okay. Like all kinds of like human behavior reasons. But the
mhm,
other thing that happens is, even when they are taking their meds as prescribed, and you'll get this, the patient's like 142 over 91. So they're
yes.
at like they're elevated, but they feel okay, right? And you're like, I'd like to add another medication, or I'd like to up titrate.
Mm.
How often do you think we hear, can I give it another month
Oh,
so that I can try? And think about it, this happens all the time in the office, right?
yes.
But then those patients never come back, right?
Never. No.
Or they come back 5 months later, and like then or they
Exactly.
have a stroke. Like, I mean, but for
Yeah.
us, we
Yeah.
can say, okay, let's do another 3 weeks. Let's really work on diet and exercise, with you understanding what the risk is if we don't do the titration. And then I'm going to come back and I'm going to talk to you again next month. And maybe
Mm,
we'll talk about doing the titration then. So sometimes you have to do a little bit of like work to get them there, because they're like, I
mm.
don't want to take another medicine, or I can't afford
Right.
another medicine,
Right.
or can I wait until this month runs out and then I'll get it up. So you can, and these are all these human behavior things. So we keep talking about AI, and of course we're hell bent on like, bringing AI
Mhm.
capabilities into, we're already like layering different capabilities into our platform. But you can't like AI, like you can't necessarily, these are human beings that we're dealing with, and they have human behaviors that are not
Mm,
always predictable,
mm,
and they might not always agree, even though we recommend, or we recommend
mm,
you do
mm.
XYZ. They might not always agree with it, and might not always be willing, and you've got to get them there and meet them where they are, so that they eventually buy in and follow along on that journey
Well,
with them.
it's really interesting, and I don't know that we have time to dive into AI today, and I know you have a lot of expertise in that area. Um, but it just, what's really interesting is we've used the most advanced digital technologies to get people to change their behaviors, largely around consuming, purchasing things. And so I think we're all aware of the success of that use of data and data analytics and advanced technology, social media, et cetera. What we haven't done yet is figured out how to use that to actually help us change our behaviors in healthful ways. And I think that may be kind of the next frontier. Hopefully it will be, as opposed to maybe we could turn some of that, learn from other industries that have been so successful
Yeah.
in understanding human behavior, human decision making, knowing how to capture people at that point, right? It's like, I mean, think about this. How is it that I mention that I'm interested in having a blender, I just say it out loud, and I go to my laptop or my phone, and the next thing I know, I've got blenders being advertised to me, right? And so, the ability, and they know who I am, and they know my demographic, and they know how to A/B test quickly with me to decide how to make sure, how to capture me. And uh, I have not heard. I mean, I'm kind of curious. I have not heard that sort of technology and approach being used to help us, maybe outside of some of the behavioral economics work that's being done,
Yeah.
but yeah, I'm curious what your thoughts are. This is a very, very different conversation.
No, I actually agree with you that that's a lot of what needs to happen. So, for example, for us,
Mhm.
we obviously we use we have AI features and tools for different things. We always have a clinician or a human in the loop, so we don't have any AI that's making clinical decisions. But we use it to help with personalization. So, for example, when we're doing a coaching call, we can surface insights, personal insights about that patient. Just like when you walk into a Four Seasons and you walk up to the desk and they already
Mhm.
know who you are and they know a little bit about you. Like, how do you help the
Mhm.
patient feel like, we're really we know you, we want to talk about things that we know are important to you, and we learn about our patients, but like, you got to surface some of those things out of the mass gobs of documentation and information that's sitting in patient charts. And so how do we surface that so that we can really get the patients to feel engaged and feel
Mhm.
supported? So, I think that's like our first step in what you're describing, which is like even more like
Yeah.
an automated, like it's listening sort of I mean, and can
Mhm.
say, hey, like if you talk about a medication, it somehow surfaces
Right.
information about that medication. And then, how do we also engage patients where they are from a digital tequity perspective
Yeah.
and understand what their preferences are. So some patients prefer text messaging, some patients
Right.
will talk on the phone. And then how do we bring more personalization to those experiences? And then how do
Mhm.
we put more precision around um, the patterns and the trends and the information that's coming through from a biometrics perspective to identify the patients that are in the highest need versus a
Mhm.
patient who has chronic bradycardia that keeps alerting for low heart rate, but we know they have chronic bradycardia that they can tolerate. It's been well established. So, like, it's not a one size fits all. And
Right.
so we start to think about as we look at like what we can do today and how we're sort of evolving that over time, it's how we put precision around patients and understanding that not every patient falls into like a standard guideline and that there's going
Mhm.
to be edge cases, there's going to be things that like you can make adjustments to create more personalization and precision around that particular patient and their chronic disease.
I just want to say, I'm glad you are where you are. I think you're doing great work. I think this direction is so critical. Um, if we're gonna have a chance at helping people with chronic diseases, it's got to be, to your point, we've got to go beyond the walls of because it just it won't work. There's not enough capacity. And again, I don't want to overstate the issue. I think obviously in-person visits are important, critically important, and but this work is really, really fantastic.
Super grateful for you to have me back on the show. I'm really looking forward to hearing how it turns out. And thank you so much.
Yeah, no, Evie, thank you, and we'll be in touch soon. Thanks, Evie.
Thanks.